Good afternoon, everyone. My name is Jose Leon. I am the Chief Medical Officer at the National Center for Health in Public Housing. Thank you so much for joining us. This is our second session of our Learning Collaborative, implementing screening of people with disabilities and functional needs during disasters. We are very glad to have two great speakers with a lot of experience on this particular topic. As you know, this session is a bilingual session, is a bilingual activity. So if you would like to attend this session in Spanish, you have to go to the interpretation feature at the bottom of your screen, click on it and select Spanish. Once you are in the Spanish room, please make sure that you mute yourself. Next slide. So these are the instructions, Zoom instructions. At this moment, all participants are muted. If you would like to turn your camera on, please do so we can get familiar with all of you. We are very happy to have health centers from all the United States. So it's always a good opportunity to meet other colleagues from other health centers. If you would like to participate, you would like to have any, if you would like to ask any questions, please use the chat feature as well. You can find it at the bottom of your screen, and you can type your question. You can also ask your question verbally. You can use the raise hand icon. Your line will be unmuted, and you will be able to participate. This webinar is being recorded, and the slides and other materials, including the recording, will be sent to you via email, not later than a few days after the end of this activity. Again, there is a Spanish interpretation available if you go to the interpretation feature at the bottom and select Spanish. Next slide.
And just in addition to the Spanish interpretation instructions, what you can also do is mute original audio so that you're able to listen to the interpreter more clearly.
Thank you, Peter. So again, we are the National Center for Health in Public Housing. We provide training and technical assistance to community health centers across the nation. We focus on the health centers, providing healthcare and preventive services to public housing residents. You know that there are almost 2 million people living in public housing. The 37% of these households say that they have at least one person with a disability. This is an extremely important topic just to make sure we know that COVID has been the condition has provided a lot of experience for health centers, specifically in the area of emergency management, but there's always the opportunity to discuss how we can help those who are in most need when there is an emergency. So we have two great panelists for today's activity. And if you have any questions, please make sure to ask your questions. We are supported by HRSA to provide training and technical assistance to community health centers across the nation. Next slide. Again, my name is Jose Leon. I am the Chief Medical Officer here at the National Center for Health in Public Housing. And I always have a colleague, Dr. Novoa Rios, who is helping us with all these activities. And he will be joining us later. Next slide. So it's my pleasure to introduce our two panelists for today's session. Marcy Roth is the Executive Director and Chief Executive Officer of the World Institute on Disability. Marcy Roth joined WID in September 2019, bringing her lifelong commitment to advancing the rights of people with disabilities and expanding disability leadership locally, nationally, and globally. Active in the independent living movement since 1982, Marcy has served in senior and executive leadership roles for national and global disability advocacy and public policy organizations since 1995, establishing, supporting, and leading coalitions committed to operationalizing disability inclusion, and establishing, supporting, and leading coalitions committed to operationalizing disability inclusion as an intersectional imperative for global social justice. We're also going to hear from Dawn Skaggs, who is the Emergency Disaster and Climate Resilience Specialist at the World Institute on Disability. Dawn is WID's Emergency Disaster and Climate Resilience Specialist, and she is a national and international subject matter expert, consultant, and speaker on the creation of disability and whole community inclusive and emergency planning, preparedness, response, and recovery for universal physical, programmatic, and communication access. She has provided training and presentations at hundreds of events for local, national, and international audiences, including radio, television, and university platforms. Without further ado, I would like to turn it over to Marcy. Good afternoon, Marcy.
Well, hi there, and thank you so much, Dr. Rodriguez. It's really an honor to spend time with you again and with the whole team. I am especially excited about this very important topic and the opportunity for us to collaborate to support the health maintenance needs of people in public housing, and in particular, the health related needs of people with disabilities of all ages. Next slide, please. I am with the World Institute on Disability. WID is one of the world's oldest disability-led organizations, founded by people with disabilities and continually led by people with disabilities since 1983. And you'll see a picture of our three founders back in 1983. And a fun fact about the organization is that Ed Roberts, the man on the left, received a MacArthur Genius Award, which helped the organization to launch. And WID was one of the world's first public policy centers controlled by people with disabilities, dedicated to the promotion of independence and full inclusion in society of people with disabilities, committed to public education and to converting policy into action. As you can imagine, a focus on health and community living has been central to the work of the organization for all of the time that we've been together. And I want to, on the next slide, I want to address the Centers for Disease Control and Prevention data around people with disabilities. You may be familiar with these data, and in fact, 26% of the US population, 1 in 4 adults, is considered to have a disability. In fact, in some parts of our country, that those percentages are significantly higher. I believe in Puerto Rico, the numbers are closer to somewhere in the mid 30s, maybe 36%. And in fact, in public housing across the country, and in discussions with the team yesterday, I think we all came to a common understanding that in public health, in public housing, the numbers of people with disabilities are probably at least 40%, maybe easily 50%, and could, I think we would comfortably agree that it's probably even significantly higher than that. Next slide, please. So, there are ongoing perceptions about who people with disabilities are and what our capacity is to contribute. I am a person with a disability. I have rheumatoid arthritis and lupus and a number of autoimmune surprises that rear their ugly heads in my life on a regular basis. And if you did not know that, you probably would not consider me to be a person with a disability, because my disabilities are generally invisible. And there are many misperceptions about people with disabilities, and as a result, there is tremendous marginalization. And so, for people with disabilities, it's presumed that, we need to be cured. It's presumed that the barriers are, our barriers, as opposed to shortcomings in society, failure to plan inclusive of the needs of the whole community, 30, 40, 50% of the population. And, when we think about disability, we need to be thinking in terms of, physical accessibility, accessibility in the built environment and in the physical environment. We also need to be sure that we're providing equally effective communication access, so that people who have hearing disabilities or vision disabilities, people with limited English proficiency, people with low literacy, people who have cognitive or intellectual disabilities, and many others for whom access to information can be so either fundamental to inclusion or fundamental to exclusion. And all of these physical and communication accessibility requirements also must be embedded throughout all programmatic opportunities for participation. And it's particularly important that we are well aware that the existing barriers that people experience on a daily basis are in fact those barriers that are disproportionate in disasters. Next slide, please. We talked a little bit about this just a few minutes ago, but important to make the point that we have typically thought about disability from a medical perspective as a consequence of a health condition or a disease or as a result of an accident, and that we've then moved from a medical model to a functional model more recently, where we think about disability as limiting function of the individual And we are really looking to move to a social model of disability, which is that the person's activities are limited not by the impairment, not by the condition, but in fact by the environment, and that the barriers are consequences of a lack of social organization. And that is why we're all here together today, because rather than thinking about people as being a liability in disasters, we have the opportunity to plan for the inclusion of people with disabilities. And we are in a position to reduce that disproportionate impact. And this, the barriers that we continue to see and the silos between our health systems, our community living resources, and our emergency management contribute tremendously, not only to the impact on those individuals with disabilities, but on our ability to improve outcomes for the whole community in disasters. So when we talk about that disproportionate impact, we have data that tells us that people with disabilities are 2 to 4 times more likely to be injured or to die in a disaster. And it is particularly important that as we're planning, that we're not just thinking of people with disabilities as being a liability in our planning for disasters, but that we're giving people the tools and resources to be able to lead, to provide our expertise, our lived experience in planning for, responding to, recovering from, and mitigating disasters. I'm now going to turn to Dawn, who's going to take us through some of our planning and connecting us with COVID initiatives.
Thank you, Marcy. As we look at this disproportionate impact that we see over and over across each and every disaster, we had a great opportunity the last few years to really observe what some of that impact and that disproportionate impact is on people with disabilities, as well as on individuals with access and functional needs. What we saw very clearly was that COVID allowed us to expose some of those barriers and some of the things that were happening in steady state prior to COVID that resulted in COVID having such an enormous impact that was incredibly diverse for different population groups. And what we saw very clearly evolve over time was that individuals who were challenged in their health equity on a daily basis, be that accessing medical care or working within medical care systems to advocate for their needs or to communicate what their needs were, or really just to get the kind of treatment that they knew they needed on a daily basis to maintain their health, safety, and independence in community living. Those things were eroded as COVID emerged and as we were more challenged with our service delivery process. And one of the single most significant advantages of COVID was that we were able to document how things might be improved, as well as some of the things we want to try and eliminate at all cost. One of those that we saw is institutionalization. As the systems were taxed, individuals who were living in the community ended up living in institutions where their health was further at risk. So what can we do with those learning opportunities, and how do we go from here moving forward to plan in advance of the disaster? What would we think about if we could go back 2 years prior to COVID impacting all of our lives, and maybe back 5 years prior to some of the phenomenal natural disasters that we're still recovering from? Some of that is taking an approach to intentional and strategic inclusive planning. Every plan that we make must be inclusive. And earlier you heard Marcy talk about and mention whole community planning. Whole community planning is a phrase that you may have heard around, but essentially what that boils down to is bringing in planning subject matter expertise, accessing all of the capacities in the community, and making sure that our community is represented when we do the planning. So we're not making a core plan for that 50% that's easy to plan for, and then layering on solutions. That we're really looking at capitalizing on the assets within the community and looking at the people in our residential areas, the people who use our clinics, as potential assets to our plan. And what that really means is making sure that what we do before a disaster can be rolled over into an inclusive plan in a disaster. If we are not taking an inclusive approach that includes the whole community before a disaster strikes, we are really not going to be able to do that in the midst of a disaster response. So that pre-disaster whole community preparedness and planning is what allows us to have a inclusive disaster response, which can minimize and, in the ideal world, eliminate those disproportionate disparities and long-term impact that we often see with people who have disabilities, as well as those with access and functional needs. So planning for this is going to be good enough, which was frequently the old traditional strategy years ago, really is not adequate. We need to plan for all of the facets, all of the sectors, and all of the skill sets, all of the needs within our community. That means when we're talking about planning with people with disabilities, that is beyond people who have wheelchairs. Marcy articulated very well. We tend to think, when we think inclusive planning, as the accommodations and accessibility needs that we can see, and plan for those. We need to remember that planning inclusively is everybody, but all of the different kinds of disabilities. And that would be visible as well as invisible disabilities, because we know that is a significant portion of the population. And with the populations we serve, that may actually be the majority of our population groups. So how do we do inclusive planning, and how is that planning strategy inclusive? We really need to be planning with and not for people with disabilities in our community. I'm sorry, I'm having slide challenges here. But that means we take a different look at our plans before we start to plan. We need to plan to plan. And that look has a couple features to it. If we want that whole community disability inclusive planning process, we look at the community as an asset and strengthening our plans by bringing diverse skills, knowledge, and resources to the table from the very beginning, not looking at who are the partners that we usually plan with, who are the obvious partners, who are the people who have a title in their role that might make them an obvious partner, who are the people that are leaders within their natural community, who are the force multipliers on a daily basis, bringing those people to the table, not as a representative contributor, but as an equitable and equal partner. Those are some of the things we do want to do. What we don't want to do is look at people with disabilities as vulnerable or expendable or a liability. In reality, the data shows that if we don't take a fully inclusive planning strategy, people with disabilities are some of the most significant users of resources in a disaster. However, if we go back to that asset-based planning strategy, they may not be. They may be contributors. They may be building the capacity with us rather than assuming they're going to be users only of the resources. And the final thing that we want to really take away that was very evident in COVID and a few of the more recent disasters is to make sure that we don't plan for disasters to supersede people's civil rights. There are rights and responsibilities that are over and above any kind of disaster situation, things that we absolutely must do and that we absolutely cannot do. And those sort of are reflected in our plans, because when we plan for the majority, we have to have some that don't make that cut. So moving forward, I want to touch on thinking about our planning process and the planning strategies. What are the things, the areas that we need to plan within? And we don't want to be looking, as I said, at people as a label or as a categorical group. What we do want to look at is what are the needs that are within this, within our population group? What are the needs within our staff and the needs within our network within the community, as well as the people that we are working with? You're seeing on this slide a way to break that down into functional needs. And those needs related to a disaster might be communication and looking at how do we make sure that we apply what we know as a need to the plan and that we plan specifically for those needs that we already know exist. Rather than planning for a particular population group, planning for the communication needs of the whole community. That probably means planning for language interpreters. That means planning quite possibly for different methods to deliver the information so that we make sure we reach people in a way and that meets their needs, that gives them direction and messaging that's meaningful to them so that they can take action to participate in their own planning and response. The second area is in maintaining health. As Marcy mentioned earlier, that is a critical piece for us if we want to make plans that are effective, that are implementable. We need to make sure that we allow and facilitate as much autonomy and independence and steady state health as possible. Independence is the next area that we look at, and that is really making sure that we do what we can do in that social model of disability to break down whatever barriers we have inadvertently or systematically created so that people can participate as equitable partners, be that in the planning process or independent emergency planning for their own person and household. If we have households that have their own emergency plans, those are households that are less likely to become significant users of our disaster resources. Safety and support and transportation are the next areas that we will be looking at when we do a plan. Safety and support, really goes throughout the entire planning process. That would apply to sheltering in place, other location sheltering, as well as evacuation to whatever the safe destination is. How do we make sure that we provide the support and the safety for those who need it without doing for and disenabling those people who really have plans and can partner with us? And so in that, those addressing those functional areas in all of our planning process, as I said, in sheltering in place, in evacuating to a remote location, points of distribution and transportation, all of these areas we need to be thinking of, and thinking of them in the context of all of the individuals who may be impacted. Because when we're talking about this type of planning, we're not talking about just one particular group. We're talking about making sure that this is integrated again into how we do things on a normal basis. So we're probably not going to be very successful creating an inclusive plan for a facility-wide evacuation if we don't have it on our minds on a regular basis. How would we evacuate from this particular meeting at this particular time of day? And looking at planning not as a vaccination or an inoculation, but planning as something that we do on an ongoing basis, a thought process that we integrate into everything that we're doing. Just like if we know it's going to rain, we prepare accordingly. And that becomes part of the way we think things through in our daily lives. And that requires really being intentional about the inclusive planning and understanding that this is not something that that you're going to do one time, make the plan and sit it on the shelf, and that will be a job well done. We need to understand that there is a revolving planning cycle, preparing who you would like to work with, who you need at the table to make sure that all of your population groups, all of the people with disabilities, others with access and functional needs have a seat at the table is step one. Putting that planning committee together and then moving into looking at what are the needs. What do you need to plan for your particular work life and geographic area? Once you have established that, looking at creating the plan. What are the things that need to be in your plan? What are the ways that you're going to strategize and do that? A plan is not very useful if it's not implementable. It's great to put something on paper, but if we cannot execute it, then we need to relook at it. And that's the next step of the planning process, is really exercising and evaluating that plan. Is it implementable? Things very often don't fall out the way that we think they're going to, or the way we're hoping that they're going to when we write it in the plan. So reviewing and exercising the plan and then revising. As you hear me talk about that cycle, it's evident that that is an ongoing process that really requires adaptation. It requires integrating that planning into the daily life. Maybe not daily, but on a regular scheduled basis. In that way, and in order to accomplish that, we really need to be making sure that whatever our plans are approved and supported by those around us. Making a plan and having a really fantastic plan is very limited in its implementation if we don't have collaboration of other agencies that we work with, other agencies that are working in the same field or with the same population group. That limits the ability for us to have a successful plan. The best laid plans for emergency and disaster response include others who have their own plans. So we can't make a plan in a silo that's really going to work for everybody. And we need to start with the plan, communicate it, ensure that we all are in agreement with leadership and the others who will be impacted by our plan. We cannot make assumptions. This slide, we're talking more specifically about the disability inclusive emergency preparedness and disaster resilience planning process. And that's really one tool that reflects a strategy that I've been talking about. In order to follow that approach and try to get as close as we can to fully inclusive planning, there are some steps that we need to take. And that would be making sure that we have buy-in from leadership. Whoever has the final decision on the implementation of those plans. There may be one, there may be a group of people who have the authority to say, yes, we will move forward with this, we will implement this, is incredibly important. If you don't have that from the beginning of that planning process, that person or that group probably needs to be represented in that original cadre of people that you bring together in order to push this forward and make sure that you're doing something that's useful in the event that you need it. The next step is really an honest look at the current activities. It's tempting when we're making plans to be very optimistic about what we do and what we hope to do. A planning assumption that I sometimes share with people is in emergency management, we plan for the worst and hope for the best. If we do it the other way around, we create a gap. Even though we don't mean to, we create a gap between what we hope to happen and what we want to happen and what can actually come to pass. So hoping for the best, but planning for the worst allows us to take a very candid look at where are our strengths and where are our needs. What are we not doing as well as maybe we should be doing? And looking back at previous disasters is a really important thing to do. We use the term lessons learned often, but unless we actually go back to those lessons and change what we're doing now, change what we plan to do in the future, there are lessons that are not necessarily learned quite yet. So that honest look at where are the gaps is a really sometimes difficult but crucial place to start. And then after we've done that, the next step would really be looking at where is our disability subject matter expertise. We don't expect everybody to be adequately knowledgeable on everything, which is why the planning process is a collaboration. And if we want to be fully inclusive of people with disabilities, we need to be accessing their subject matter expertise. They are the most familiar with the disability needs. They're also the most familiar with disability accommodations and what needs to happen to get those needs met. So they're a critical, important resource. And then really looking at how do we take that resource information and address it and apply it to the gap that we know is there. And again, we're going to look at that planning cycle, analyze, is this meeting the needs? What do we need to do next to go from meeting the letter of the law for inclusion to doing a good job of inclusion in our plans, to really feeling like we have made every effort to include the entire community and all of the disability accommodations that may be needed in a disaster. So achieving where we want to go is a multi-step plan. It's a multi-step process that the more you do it, the more you need to do it, because we will always see areas that we can do better, always see things that we can improve, and always have the opportunity for new subject matter expertise to come in and collaborate with us. The first area that we need to do that I've already mentioned, so we'll talk about this fairly briefly, is that self-evaluation, that preparedness is dynamic and we're always going to be making improvements. That said, in order to do that, we need to maintain an open mind. A lot of times it's tempting to feel like making a plan is the job. And when the plan is done, the job is done. Where we really need to change our thought process to look at how can we do this? And even when we have a plan that we feel we have been very inclusive in creating, that we feel like is applicable to the needs and the gaps that we know are there, maintaining an open flexibility to alternative solutions. There's always another way up the hill. And sometimes we may have a plan that is adequate, that gets the job done, that is inclusive, that makes sure that we have evacuation pathways that are sufficient for mobility devices, that don't have barriers for people with vision disabilities, making sure that we have facilities that can accommodate a service animal, making sure that we have addressed the audio and the sound, not just for people with hearing disabilities or vision disabilities, but for people with cognitive and intellectual disabilities who may not be able to function in a large congregate setting very well without some other additional accommodations. We may have that plan, but there may be a better way to be improving that plan beyond that. So keeping that open mind and understanding where your skill sets go and where you need to go from there. Because as I mentioned, the individuals with a disability are the subject matter experts. And an individual who is dependent on electricity will be able to tell you what they need. And then that collaborative strategy to make sure that your plan includes those resources is critical to the full involvement. So beyond the self-evaluation, the deep dive process looks at when do we need to bring in additional expertise? What does that look like? What do those partnerships and relationships look like? And in order to make our plans for disasters fully inclusive, we have to unpack that a little bit. Actually unpack it a lot, right down to individual plans. If we have a plan for our agency or our program that addresses the needs of the program, but assumes that individuals are going to be there, that the staff is going to be able to provide the services we plan for without redundancy, that we know who's going to be in the building or participating in the program when we have the disaster. And those personnel and those individuals don't have their own plan, there is a very big barrier to the bigger plan. So we start small, start with individuals and individual plans. That includes everyone. So going back to what I said about integrating emergency preparedness planning into our daily life, when we are working with people, when we are interacting with clients and peers and leadership, making sure that we are addressing, do people have their own individual plan that meets their individual needs, that encourages and supports as much independence and safety as possible? Then we build from there to see what are the operational policies and procedures that we need to integrate in order to support those individual plans. A lot of times when we're talking about emergency preparedness planning, we're looking outward at residents, at clients, at consumers, but we need to be looking at inward as well, at our staff, at the vendors that we work with, at the coordinating agencies that we work with, making sure that what we're doing supports that full integrative planning process. And then what that organizational preparedness then looks like. And finally, how do we make sure that that is integrated and that the planning process for individuals with a disability, be that our program participants, ourselves, or our peer agencies, those are inclusive of all of the relationships, and that we practice that on a daily basis. So I'm going to turn it back to Marcy to sort of wrap us up with how do we look at what are the considerations specific to public housing and health centers that we need to be honing in on to make sure our plans are fully inclusive of people with disabilities. Marcy?
Thank you very much, Dawn. And this is Marcy speaking. So when we very specifically look at public housing, and when we look at the imperatives that we've been talking about for not only planning, but inclusion of people with lived experience, our disability inclusive emergency planning and disaster resilience initiative looks at this from a variety of angles. And really, this is usable in any setting. Today we're focusing on public housing, but it as well applies in those public health centers. It applies in a corporate environment, a retail environment, in just about any place where we need to be considering the whole community and their needs in a disaster. So first and foremost, we always have to have leadership buy-in. Without leadership buy-in, it's almost impossible to improve the outcomes for the whole community. And along with that, we must have policies in place, not so that we can dust them off in the middle of the disaster, but so that we all are planning from a shared understanding of what needs to happen. We need to be doing this from a culture of inclusion, making the assumption that everyone has a role to play and everyone can contribute, and that the barriers are not in the individuals, but those barriers exist in environments. Those physical access barriers, those effective communication access barriers. As we're looking at how to improve those outcomes from the next inevitable event, as we're addressing our communication obligations, are we truly looking at how we're giving people actionable information in formats that are accessible to them? If we're only giving people information that is not actionable by them, then our expectations are unrealistic if we expect them to be able to take personal protective measures. So in the public housing setting, if what we're doing is slipping a note under the door, or if we're making a public announcement using only one modality, if our building evacuation plans make the assumption that people are going to be waiting for someone to come and rescue them, when in fact, the likelihood is that no one is going to come and rescue them. And certainly if there's a fire or some sort of toxic environment, or a an active shooter, those plans for people to wait for someone to come are probably not realistic. Those accessibility requests that people have, if, whether they are residents or workers, those workers in public housing have to be able to have their accessibility requirements met. And we need to be sure that when we expect people to come to work in a disaster, we have to be sure that their family has their needs met. It is unrealistic to expect that they are going to be able to leave their family behind if their family is not adequately prepared themselves. So in public housing, are we looking at how to make sure that everyone is able to perform the functions that we're counting on them for? How are we training them? How are we addressing the mental health needs of the people in public housing, the people providing supports in those environments? How are we supporting people, back to what Dawn was talking about earlier, maintaining their health, their safety, their independence? And are we exercising? Are we taking the time to pose real world challenges in a fail-safe environment, not to show how fast we can get everybody out of a building, which is, what we, back in elementary school, I think most of us had those fire drills. The goal of exercises and drills is not to be faster than the last time. It's to pose real world challenges in a no-fail environment so that we can figure them out. So that's the perfect time to exercise whether or not we can actually get help to people. If the building has evacuation chairs, everyone needs to know how to operate those evacuation chairs. Even people who are not going to be pushing the evacuation chair, but are going to be riding in that evacuation chair. Everybody needs to know how to operate it. We all need to have opportunities in daylight, in nighttime, in weather that is inclement. And we need to be exercising regularly and with new priorities every time. So next slide, please. So the bottom line is that our goal in our disability inclusive emergency planning and disaster resilience initiative is that we leave no one behind. Leave no one behind. And we welcome the opportunity to work with you all to help you to achieve a plan that is actually inclusive of the whole community that you serve and will improve the outcomes when the inevitable next thing happens. So thank you all very much. And I think we have some time for questions.
Yes, thank you, Marcy, and thank you, Dawn. This presentation has been extremely useful, and thank you so much for the opportunity to talk to you about this particular issue that is so important for community health centers and specifically those serving public housing residents. Thank you so much. So we have some time if you have any questions for Dawn or Marcy. You can ask your question verbally. You can use the raise hand icon. Your line will be unmuted. If you would like to ask the question or type your question, you can use also the chat box. And even if you have your question in Spanish, we are going to translate your questions. So please feel free to ask questions to our panelists. As a reminder, just after this LC session, there is a post-survey evaluation, post-activity evaluation. Please make sure that you complete the evaluation. It's very useful for us to hear from all of you. And our next session is on April 19, so it's a week from today. So if you have any questions, again, please feel free to ask any questions. Let me go and see the chat box and see whether there is any questions, or Fidel, do you see any questions, or is there anyone trying to chime in on this?
Not at the moment. Thank you.
Thank you, Fidel. So I would like to ask a question. Dawn, you provided some really good information about some goals, and I saw a couple of things that are interesting for health centers, like the transportation issue. It's extremely important for health centers, to plan on how they are going to help patients during an emergency, specifically people with disabilities. We've been talking to some of the health centers about how they make sure that the patients can get health services during an emergency, and most or some of them offer transportation. So patients can go to the health center, get their prescriptions, and use all the preventive services. What is the strategy sometimes, and this is something that we discussed yesterday, or some strategies to work with some community partners when you don't have that transportation piece, and you need to offer that to your patients. Have you seen in your experience any collaborations with other organizations providing transportation?
We have, and I'm going to allow Marcy to join me if you'd like to. As you mentioned, looking at other organizations is really critical. And one of the important features to that is making sure you do that outreach and make those partnerships and agreements in advance. In a disaster is not the right time to be looking for accessibility resources. And so they may be contracts that are used on a daily basis or in steady state times, where you want to make sure you have that emergency language written into the contract. If it's not a formal contract that you're working with, you may want to have memorandums of understanding, something that's established in advance so that you know those resources. It's important to have the conversation with those other agencies in the community to make sure that you have visibility of where they are making agreements with. We see with some regularity, people are trying to use the same resource in a disaster, and there's only the one resource. So making sure you have a really accurate and realistic understanding of how many resources you have, what those resources are, because as we all know, there is no one accessible transportation that would be appropriate for everyone. And being very realistic about that assessment so that you can get a variety of resources at your disposal. Some individuals may need to transfer laying down, and others may need an accessible vehicle that can accommodate a wheelchair. Still others might just need a particular type of vehicle height or van size. So it's a very diverse options that you might have. And to get a feel for, when we talked about that self-evaluation, really thinking about what are your realistic needs, and then reaching out to the variety of places you might find that. and then establishing those relationships and agreements in advance. Marcy, did you have anything to add to that in the last few minutes?
So this is Marcy. Some examples of where you might find those resources. School systems have buses with lifts. If you're needing them during the school's evacuation process, that's not going to be a good resource. If you're needing them when school is closed, it might be a fabulous resource. You'll need to know who has permission to drive those vehicles, and really importantly, who has the keys. Yeah, we could tell stories about that. Another resource, if you're near an airport, that airport may have shuttles that have lifts, and you know, if they're in the process of evacuating, they may not be a good resource. But if the airport is closed, they might be a great resource. Car rental shuttles as well, and senior centers, and companies that retrofit vehicles to be accessible. You know, all of these are some of the ideas for how you can enter into an advanced planning relationship. And, you know, maybe your public housing setting, because you're providing health maintenance in that setting, or because you're working with your local public health folks, you may be able to offer some of these folks a quid pro quo, where, you know, they may need some of the space or some of the resources or some of the supplies that you might be able to offer. And so it's not just a one-way relationship. It's really a collaboration between lots of folks who collectively can have a very significant impact on the outcomes for the whole community. Because as we all know, the imperative to help people to maintain their health, their safety, their independence, it's not only good for them, it's good for the whole community. We want to keep people out of those acute care environments always, and especially in an emergency or disaster situation, when those resources already stretched on a daily basis are at their absolute, you know, closest breaking point.
Thank you, Donna. Thank you, Marcy. Great response. We are at the top of the hour, and I don't see any questions, or I don't see any hand raise icon visible. So I would like to thank Donna and Marcy again for this great presentation, and thank you for the support that you are providing to the health centers. Thank you so much. To the attendees, thank you so much. And again, our next session is next Tuesday, April 19th, and same time. And the next session will be in Spanish. And if you would like to attend in English, we will have our person who will be interpreting our next session. So thank you so much again, and have a great afternoon.
Thank you.
Thanks so much.